Okay, we'll just get started, and if anyone else joins, they can just join halfway in. I'm Simran. I'm one of the 5th years, and I'm currently on my Obs and Gynae rotation.
I'm Prithi. I'm also one of the 5th years, also on Obs and Gynae right now.
So what it is, we'll just go through some foundation concepts from Mod B, so your gastro and ortho room kind of rotations. So the way we'll split it is, I'll start off by speaking about your bloods, your LFTs, and your Hep B serology. And then I'll pass over to Prithi and she'll speak a little bit more about your X-rays, so your abdo imaging and your ortho room X-rays as well. If at any point you have any questions, please feel free to just unmute and answer or question, or just ask a question or whatever. Okay, so let's start with the liver function tests. So you've got your AST and your ALT are your aminotransferases. They're fairly non-specific, AST in particular. So you've got, it's producing your liver, heart, muscle, and your blood cells. And so when it's increased, although it does mean that there could be some sort of liver damage going on, because it is fairly unspecific, it can be risen in other things. So stuff like your rhabdo, your MIs, your AST will also rise. So it's important to look at the entire LFTs as a whole, other blood tests, and your vignette as well, just to make sure that whatever picture is going on, you've got the right thing, rather than just assuming it's liver because it's in your LFTs. And then you've got your ALT, which is slightly more specific. So producing the liver, kidney, and muscle. And the same, if it's risen, it implies some sort of hepatocellular injury going on. And we'll talk a little bit more about the ratios later on as well. Then you've also got ALP, which is produced in liver, but it's also a marker of bone turnover. So if it's increased, it implies some sort of cholestasis, so your bile getting stuck throughout your bile ducts, whether that's like sclerosing cholangitis, you've got primary biliary cholangitis. But because it is also a marker of bone turnover, it's increased in like adolescents and children. It's also increased in pregnancy. So it's not really so relevant for your year this year, but you have like obstetric cholestasis. So cholestasis in a pregnant woman. So your ALP will be increased, but you have to just look at other things in its entirety to see you've got the right diagnosis as well. And then you've also got GGT. So it's producing your liver, pancreas, and kidney, but it's not producing your bone. So when it's increased, it also does imply cholestasis, but it can also increase with things like toxins, so alcohol, drugs. And so it's important to look at ALP and GGT together. So if one is risen, so ALP, for example, is risen and it's an isolated rise, you can kind of think of things other than a liver pathology. And then looking at your synthetic functions, so your bilirubin, which is essentially to a breakdown of heme from your blood cells. And if it's increased, it implies some sort of hemolysis, or if you're producing bilirubin faster, then it can be conjugated. So something like Gilbert's or Gilbert syndrome. Does anyone know what it might present with, what like an increased bilirubin might present with? Nope. So you might present with jaundice if you come with an increased bilirubin. So someone with Gilbert syndrome might just present with yellowing of the skin after some sort of like stress in the body, whether that's like an illness or they're just fatigued. And then you've also got albumin. So it's a protein synthesized by the liver, but it's also a marker of inflammation. So it may also rise if you're, say, dehydrated, things like that. Sorry, may also decrease if you're dehydrated, but it is also a marker of hepatocellular injury. So when it's decreased, you're looking at more sort of like a chronic picture, just because our albumin isn't really affected until cirrhosis, because the liver can function with only like 10% of its like working capacity. And then you've got prothrombin time as well, so your INR. So looking at how much time it takes for your blood to clot through the extrinsic pathway. If you can remember back to pre-clin, does anyone know what clotting factors in particular we're looking at with the liver? No worries. So you're looking at T7, 9, and 10. It's not so important now, but when you do get to heme, you will need to know things like intrinsic and extrinsic pathway. So you will need to brush on pre-clin knowledge as well, because it's quite important. And so if the prothrombin time is increased, you're similar to albumin, looking at sort of chronic picture, quite a severe and sinister liver damage, or further down the line as well. So this is what your LFTs might look like. The reference ranges change from like different scenarios, so your passing is different, but it's important to note that in your final exams, you'll get given your reference ranges for whatever like value they give you, so you don't need to remember them, but it is a good idea to just have an idea of what looks wrong and what looks right. So for example, here the AST and ALT are thousands, which should straight away ring alarm bells in your head when looking at this. So if we think about how to work through an LFT report, start off by looking at the ALT and AST levels, the aminotransferases. So if the ALT or AST is risen by 1,000, like in the previous report, you want to consider things like drugs and toxins, so your overdoses, any like acute hepatitis or ischemia, so things like blood curare, when you might have like a blood clot affecting the blood flow to the liver. So yeah, so that's the things to kind of think about when you see that it's over 1,000. And then looking at the ratio between the two. So AST generally is a marker of, or is kind of indicative of alcoholic use, or alcoholic overuse rather. So looking at the ratio between AST and ALT, if the ratio is above 2.5, it's generally kind of quite likely to be an alcoholic hepatitis. Obviously, it's not a hard and fast rule, but it's for SBA's most likely answer. The way I used to remember it is, well, the way I still remember it is, L is for liver, so it's more likely to be your liver marker, and S is for like spirits or shots. So the AST is like the alcoholic when you're looking at, so it's to be larger in an alcoholic hepatitis. And then we're looking at ARP and GGT. So I mentioned this earlier on, that if you're looking at ARP and it's just an isolated rise in ARP, you can kind of imply that it's some other sort of bone pathology, whether that's actual kind of bone pathology with bone turnover. Whereas if ARP and GGT are both risen, you can think about more of sort of a cholestatic picture, whether that's just kind of like biliary cholangitis or whatever else it might be. And then looking at the bilirubin, so if it's increased, think about sort of a more holistic picture, what could be going on. And it is divided into certain things. So it's divided into your total bilirubin, so all the bilirubin flowing through the biliary system, and conjugated and unconjugated bilirubin as well. And we'll speak a little bit more about bilirubin metabolism later on, just so you can get an idea of where the pathology is, depending on whether it's conjugated or unconjugated rise. And then finally, looking at your INR and your albumin levels. And so, like I mentioned earlier on, you're looking at a more chronic, sinister picture if these have risen by quite a lot. With like an acute hepatitis, it's unlikely that your INR and albumin are going to rise too much. So if, for example, the answer between like a chronic or acute Hep B, look at the albumin levels, look at the INR levels to see where, like how long the pathology has been around for. Quite a few cases. Can anyone tell me what they think these LFTs are pointing towards? Okay, so you're looking at an alcoholic hepatitis here. And the reason for that is we're looking at the AST and ALT ratio. You can see there's a ratio of 2.5 with the AST being higher. And so it's indicative of something alcoholic going on. The reason it's not acute Hep B is because we spoke about before, you're looking at a much higher rise in your aminotransferases, something around the 1,000s. And with both hepatocellular carcinoma and chronic Hep C, you're looking at a more sort of kind of severe picture. Your albumin might be raised because you've got inflammation. And the same with Chiari as well. You're looking at a more severe rise in your AST and ALT because it will cause some sort of hepatic ischemia. A couple more cases. You can message in the chat as well if you can't unmute at the moment. Okay, no worries. So with this, you've got quite a high rise in your ALT. So there's a few things you want to consider with this picture. Think about your drugs, toxin overuse, any ischemia, and acute hepatitis. So we can immediately then rule out a chronic Hep B. A primary sclerosing cholangitis will cause a bigger increase in ALP. And so whilst the ALP is risen in this picture, it's not really as severe as the ALT or AST for that matter. And Wilson's disease is similar, so it's going to cause a more sort of chronic picture. You're going to get cirrhosis, and you're going to get like the classic like Kaiser-Fleischer rings, and they also get like a Parkinson's sort of picture as well. So that rules us down to Comox club use and paracetamol overdose. Anyone want to take a guess of which one it might be? So there is a part of the page specifically about drug overuse and talking about whether it causes a hepatocellular injury or a cholestatic injury. And so Comox use does cause a cholestatic picture. And so in this case, we're saying it's obviously not that because the ALP hasn't risen as much. So it's likely to be a paracetamol overdose. It's important to know that anything that is metabolized by the liver can cause a picture similar to this as well. We've got 2 more cases on this, and we can move on to bilirubin metabolism as well. Okay, so with this question, if you look at all the reference ranges, you can see that both the ALT and AST haven't risen. They're within the reference ranges along with ALP. So is the GGT, albumin, and INR. So the only thing that's risen here is bilirubin. So we haven't got a vignette to go by. But from all these cases, you can see that the only one likely to cause an isolated rise in bilirubin is going to be Gilbert syndrome. The rest of them will cause either a cholestatic picture or some sort of other hepatocellular injury, which will cause a rise in the aminotransferases as well. And so with this, we can imply that it's Gilbert syndrome, which is a fairly benign syndrome, but you just need to make sure that it's nothing else more severe causing that increase in bilirubin. And last case before we move on. I'll just explain if no one can, if no one wants to answer at the moment. So with this, we've got a rise in ALP and GGT along with bilirubin. So that implies cholestatic. So your Hep B infection is going to cause, whether it's kind of acute or chronic, likely to cause some sort of change in aminotransferases. Hepatocellular carcinoma, similarly, is going to cause some sort of hepatocellular injury. And non-alcoholic fatty liver disease as well will cause a rise in your aminotransferases. So really, if you kind of just go with that, it's a cholestatic injury. So if we speak a little bit about bilirubin metabolism. So it starts off in your blood cells. So you've got the hemoglobin in your red blood cells will break down to hemoglobin. And it's then that goes on to form your bilirubin. So the red blood cells will enter the reticular endothelial system in the liver and the spleen, and are then engulfed by macrophages. So this then causes heme to break down into your bilirubin and iron. The iron then can recycle along with the globin to create more red blood cells. And the bilirubin, which is now unconjugated, will enter the system. So unconjugated bilirubin isn't water soluble, and so it can't really free flow through. So it needs to be bound to something like a protein, like albumin, in order to flow through kind of blood or wherever else it needs to go. And so this bilirubin albumin kind of compound will enter the liver system and dissociate. The unconjugated bilirubin will be taken by hepatocytes and made water soluble by something called UGT. It says on the screen what it actually is, but I'm not going to try and say that. But in this case, it's specific to bilirubin, so it's BUGT. And so it's now water soluble, and so it can be excreted in bile and urine. And so this conjugated bilirubin is now secreted into the biliary system and is a component of bile. It can then be reduced to urobilinogen in the intestine, particularly the large intestine, and can kind of go further in the intestines and go back into the system to form something called urobilin. And that's what's then excreted in stool and excreted through kidneys into the urine, and what gives it that sort of yellow colour and gives stool a sort of brown colour. I think it's kind of a bit weird to get your head around if you haven't learned it already, but I think Osmosis has quite a good video on it if this didn't make too much sense. But I would say it's definitely worthwhile revisiting pre-clin knowledge to get your head around this, because it does help understand things in the long term. So looking at jaundice, so we can see that your prehepatic jaundice is going to be unconjugated because it's before the liver. So it's before the bilirubin's had a chance to become conjugated. And so because we said that it's conjugated bilirubin that then leads to urobilin, that gives urine and stool that funny colour, the urine colour and stool colour of prehepatic jaundice will be normal. And we spoke about causes of it will be something like hemolysis. It's before it got to the liver, it's not going to be anything to do with the liver. So it's just that bilirubin is being produced faster than the liver's ability to conjugate it. You then also have intrahepatic jaundice, which is caused by anything related to the liver itself, so drugs, viruses, other toxins like alcohol and stuff like Gilbert syndrome. And that's a sort of mix of conjugated and unconjugated because it all sort of happens in the same area, and it gives urine that dark colour. And the reason it doesn't give stool the weird colour is because it hasn't had a chance to go through the large intestine yet and be converted into urobilin once it kind of reacts with all that bacteria. So it's only urine that will have that colour. And posthepatic is anything after your liver, so anything gallstones, anything blocking the bile duct, so tumours, your sclerosing cholangitis, biliary cholangitis, which is affecting the actual bile ducts, sclerosing affecting extrahepatic and intrahepatic, and then obviously cancers as well. And because that's a conjugated bilirubin increase, you're going to get dark urine with that and pale stool colour. So it's just worthwhile knowing for your SBAs or just for futures, where if you're clerking people and this is what they present with, you can kind of get an idea of what their pathology might be and where it lies. We have got a few more cases. If no one wants to unmute or you're unsure of the answer, you can just go through it.
Yes, please. That'd be good.
Okay, so we just want to find out if this is a prehepatic, hepatic, or posthepatic jaundice. And in this scenario, your conjugated bilirubin is just within the reference ranges, and your unconjugated bilirubin is above the reference range. So we know that unconjugated is prehepatic, so this is looking at a prehepatic sort of jaundice. So this is likely to be a sort of hemolytic anemia, or some sort of hemolytic picture, or it could in fact be an inherited condition as well, like Gilbert's, or maybe that's like less likely to be symptomatic, so maybe lower down your differentials. We've then got another case of a 56-year-old male coming to the clinic looking jaundice with a past medical history of alcoholism. So that's already your first clue of where the jaundice might lie or kind of might arise from. there's an increase in conjugated bilirubin and unconjugated bilirubin. So you've got a mixed pattern there. So it's more likely to be hepatic. So maybe like an alcoholic hepatitis. And then last case, following a similar sort of pattern, you've got a raised conjugated bilirubin and a normal unconjugated with dark urine and pale stools. It's sort of all pathognomonic of a post-hepatic jaundice. So speaking about hepatitis B, if you haven't come across the serology already, I think it looks a little bit confusing. There's a lot of random letters, but it's one of the easier things to understand once you have got your head around it. What I would recommend is understanding why everything is the way it is, rather than just remembering like ways to remember things. I will speak about them as well, but in general, especially with hepatitis, it comes up quite a lot. It'll come up this year for you. It comes up again in 5th year in both sexual health and as part of the antenatal screening. And just generally, it comes up quite a lot in hospitals. So if you can understand it well, I would really recommend it. So if you hopefully remember back to pre-clinical, your antigen is your marker. So if you've got a hepatitis B surface antigen, that's implying that you've got the actual infection itself. So a current hepatitis B infection. And if you've had that antigen for over 6 months, that's sort of indicative or defining a chronic infection. You then also have your hepatitis B surface antibody, which implies that you've got some sort of immunity to the antigen, whether that's through past exposure or past immunization. And so if you're born in this country, it's more likely to be immunization. So to differentiate between whether it is exposure or a vaccination, you can look at the hepatitis B core antigen. So this identifies whether your bodies have been exposed to the actual virus itself. So if it's positive, it indicates that you've had the infection. And if negative, then obviously vaccination. And it's important to note at this point, so there are 2 types of core antigens. You can have IgG or IgM. In an acute infection, you're likely to have both of them identifiable, whereas IgG persists for over 6 months, where IgM isn't identifiable. So if you look at serology and there's only IgG present, you're looking at a more sort of chronic picture of hepatitis. And then finally, you've got your hepatitis B E antigen, which just applies high infectivity. So you've got a high viral load, you've got a rapid replication rate. And this is sort of like a picture of just what you could expect from different reports as well. The way you could remember it, if you didn't want to learn what everything means, looking at the anti-HBs is the antibody. So you can use the S to be like, you're safe. So you're safe from the virus because your body will recognize it. Anti-HBC, so your core antigen, is that you've caught it. So if anti-HBC is present, either IgM or IgG, it implies that you have caught it at some point. And then HBeAg is infective, if you spell it with an E. And they're not the best ways to remember it, but they are useful if you can't fully understand the antibodies and antigens. So if you've got none of them present and they're all marked as negative, you are susceptible to the virus just because your body won't recognize it. You haven't had a vaccination or previous exposure. If just the antigen is present, and then you've also got your core antigens present as well, it implies an acute infection because IgM and IgG are both present. If, however, it's just IgG because it persists longer than 6 months, that's a chronic infection. If there's no antigen, surface antigen present, but there is a antibody present, an IgG, it implies you've had it before. And so you're safe, but you've also caught it. So it's a past infection. And if it's just the surface antibody present, you have been vaccinated from the virus. We'll just talk through these. It might be a bit easier. So looking at these, there's a positive antigen, positive core antigens, and a negative antibody. So you're likely to have an acute infection. Does anyone want me to explain this? Okay, I'll move on. For case 2, if you have a positive antigen, positive IgG, and negative IgM, that implies chronic. So you've got a chronic hepatitis infection because IgG persists, and you've got a current infection. And finally, if you look at the surface antigen is negative, your core antigen is negative, and your surface antibody is positive. That implies you've never had the infection, you've just been exposed to it, so it's like to be a vaccination. Does anyone have any questions about hepatitis or LFTs? Anything you want to go over? Bilirubin? Okay. We move on to Prithi, and she'll talk about some imaging.
Okay, so hi guys. I'm just going to talk through some X-rays. So for gastro and for ortho/room. So start by. Okay, there we go. So like with any interpretation, any module you're doing, you always want to start with confirming the patient's details, and this does get you marks in exams like OSCEs and things. And doctors kind of just expect you to do it on the wards as well if they are asking you to interpret something. Abdominal X-rays are probably less likely that you're going to be interpreting them in the hospital, but it is something that could come up in OSCE, so it's just important to make sure that you do try and practice doing it. So yeah, you just need to go through the patient's name, their date of birth, and either hospital number or NHS number, the date and time the film was taken, why the film was taken, and that could be through any history that was taken or just sort of background on the patient, and any previous imaging that you can use for comparison. And usually this is unlikely to be available, possibly if you're in the hospital doing this, but for exams it's good to say that you would do it. Okay, next is with any X-ray, it's just good to have a systematic approach just to make sure that you're covering everything that's on the mark schemes. So TARP is something that we use for abdominal X-rays. So T is for the type, and that is the position of the patient when the X-ray was taken. So either supine, upright, or lateral decubitus. The most likely one will be supine, but the others are a bit more rare. And lateral decubitus is just with the patient lying on their side. All of abdominal X-rays are usually AP X-rays, so it's important to mention that as well. So that just means that the X-ray is being taken from the front. And then moving on to R is, so A is for the area. So that's just ensuring that the whole abdomen can be seen. So from the diaphragm right down to the pelvis, and that neither side is being cut off, so you can see the whole view. R is for rotation, and that's important just to make sure that you can see the vertebral bodies in the midline, because it can distort what you're looking at. And P is for penetration, so that's just the quality of the image. And at the start, it might be a bit confusing to look at, but it's just good to remember that the denser whatever you're looking at, the whiter it will appear. So black would be gas, dark grey might be fat, light grey is like soft tissue or fluid. If it's nearly white, that could be bone or calcification. And if it's pure white, then that's most likely to be some kind of metal implant or mesh indicating a previous surgery. Okay, and the main bulk of interpreting is the BBC approach. So B stands for bowel and other organs. So here you can see we're mainly looking at this small bowel, which will be in the center of the image, and you should be able to tell this because they'll have mucosal folds that would span the full width of the bowel, and these are called valvular conventus. And the large bowel is usually peripheral, and that's how you'll be able to differentiate it, and it frames the small bowel. And these have Haustra markings, and they're usually thicker and don't span the whole length of the bowel, so that's how you could differentiate between the two, which is quite important. And you might also be able to see some feces in the cecum, which would be somewhere around here, and that might have a mottled appearance. And the 369 rule is something that you might have heard mentioned on the wards. It's just important to know because that's the markers that we use to determine if we think there might be some kind of obstruction. So we expect that with the small bowel, it should be no bigger than 3 centimeters. The colon should be, so the large bowel should be no bigger than 6 centimeters, and the cecum should be no larger than 9 centimeters. And if it is bigger than any of this, then yeah, some kind of obstruction might be happening. It's really rare that you'll see other organs on the x-rays because we don't really use x-rays to see other organs, but you might see some, if you do see anything, if you're not completely sure what it is, probably just steer away from mentioning it. One other thing is you might see a gas bubble around the stomach, like around here somewhere, and that's normal, and it's not kind of abnormal in any way. The other thing is that you might see some calcification in the gallbladder, which would be right upper quadrant, so around here, and that might indicate something like pancreatitis, like chronic pancreatitis, or in the gallbladder, it could indicate some kind of gallbladder pathology. And if you could see some clips, which would be obvious, and then would be bright white, it could indicate some kind of gallbladder removal surgery. So now moving on to the second B, which is bones. So you're looking at the spine, the vertebral disc, ribs, sacrum, the pelvis. You might be able to see some kind of pathology unrelated to kind of gastro. So it might be osteoarthritis, some kind of fracture, any bony mets you might be able to see, and again, kind of pancreatitis looking calcifications. For C, and if you see any calcifications along where the renal tract would be, then this could indicate some renal stones as well. And the last thing is, just like with any other type of imaging, it's just important to mention any artifacts that you can see. So that's any medical device that you can see within the X-ray. This might be NG tubes, PEG lines, in particular for abdominal X-rays. And finally, it's just important to summarize what you have seen, and you can suggest further investigations. It just makes you look a bit more slick. So for gastro-related things, you might need an abdominal CT, an ultrasound, a chest X-ray might also be needed if you think there's some kind of perforation, and you'll be able to see that on a chest X-ray as well. And it's also good to just suggest some differentials at the end. Okay, so this is just with some spot diagnosis. If anyone does want to guess, if not, I can just go through it. Okay, so this is a small bowel obstruction. The more you look at the X-rays, the easier it will be to identify. I know it was quite confusing just before OSCEs when we were doing it, so just try to look at quite a few and you'll just get used to identifying them. So the reason that this is a small bowel obstruction is because you can see that the small bowel is quite central in the image, and it's dilated above 3 centimeters. And again, once you look at more X-rays, you'll be able to tell what dilated looks like. And the folds here are really prominent, and sometimes they're called a coiled spring appearance. So if you see something like that, it kind of suggests small bowel obstruction. So it wouldn't be large bowel obstruction because that you would see more peripherally. Toxic megacolon would be more focal dilation, and it would be bigger than 6 centimeters. So it doesn't quite meet the criteria for this X-ray. Small bowel adhesions is not something you would be able to see on an X-ray, but it is one of the most important causes of bowel obstruction. So it's an important one to know that you'll just be able to see once the patient's opened up in theatre. And for pancreatitis, that would just be looking for calcification in one particular region, like I mentioned before, somewhere up there. Okay, just gave away the next answer. So the next one is large bowel obstruction. And like I mentioned before, the reason this is large bowel is because you can see that it's more peripheral than the small bowel obstruction. I hope that's easier to see. And you can tell that it's quite large, so it's dilated to above 6 centimeters, which is the cutoff. And again, for toxic megacolon, it would be more focal. And so you can see also that in this image, the folds here, they don't span the whole length. So that can show that there's some kind of dilation. Can anyone spot any other artifacts they can see in this image as well?
Is there a hip replace, like hip replace?
Yeah.
Hip, yeah.
Yeah, perfect. So there's a hip replacement here. And yeah, that's important to mention if you do see this in exam, for example, like in an auscultation, because there'll definitely be marks for being able to spot that. Okay, next one. Does anyone want to take a guess? I think I've kind of narrowed down the options. Okay, if not, so this is toxic megacolon. So this is the focal dilation that we can see. And it's very large, so it can kind of differentiate between the others. And so toxic megacolon is an obstructive pathology, like with small or large bowel obstruction. It's more because to do with toxins that cause inflammation and damage to one of the layers of the gut. And this causes colonic paralysis, and that is what causes the dilation rather than an obstruction. And the reason that this condition is important is because it can put a patient at risk of perforation. And so does anyone know any causes of toxic megacolon? Okay, so one of the main causes is IBD, so inflammatory bowel disease. So that includes ulcerative colitis and Crohn's disease. And infection can also cause toxic megacolon, particularly a hospital-acquired one. So does anyone know what that could be? So it would be C. diff is a really important cause of toxic megacolon. So it's just an important one to know. Okay, here. Does anyone know what this sign is? Okay, I'll just go through it. That's okay. So it's a coffee bean sign. So it just kind of looks like what a coffee bean would look like. So that's why they call it that. And it's associated with a sigmoid volvulus. So a volvulus refers to kind of torsion or twisting of the bowel around its mesenteric axis. So it's just kind of a twist in the bowel that you'll be able to see. And so the coffee bean sign is an important one that's associated with the sigmoid volvulus, which is kind of the end of the large bowel. And you can tell that's different from the cecal volvulus because you wouldn't see a coffee bean sign in that one. But does anyone know what sign you would see if it was a cecal volvulus? Okay, no worries. So it would be an embryo sign. So I guess it's kind of hard to see in this picture, but it's kind of like an embryo sitting in a room kind of sign. There are some are really obvious, but yeah, you kind of just have to look for it. Okay, the next one. Anyone know what this would be? What sign this is?
Is it lead pipe?
Yeah. So you can see here is where we're looking at. So there's loss of normal Haustra markings, and that's due to chronic inflammation of the colon. And so you can see that the bowel is kind of flat and tubular, And do you know any causes of this? So IBD again, so one of the main causes of a lot of things in gastro. So ulcerative colitis and Crohn's is some of the main causes of this. So Wriggler's sign, it wouldn't be a Wriggler's sign because that's typically a double wall sign. That is because of it indicates free air in the abdomen, and that might be because of a duodenal ulcer. And I found it quite hard to look at, find it in abdominal X-rays last year. So it might just be worth having a look through to see if you can identify it. Thumbprinting, it wouldn't be thumbprinting because that is to do with mucosal inflammation, which is also a sign of IBD as well. But you're looking for more the haustra projecting into the lumen, which this doesn't really show that. Cogwheel sign is something to do with obs and gynae, so that's not for this year. And a string sign is related to Crohn's disease, but it's not usually seen in an X-ray. So lead pipe, there we go. Okay, so now moving on to ortho X-rays. So like with any interpretation, again, just make sure you start with patient details. So I don't think I need to say it again. Just make sure that you kind of cover these things before, and it kind of gives you time to look at the X-rays and kind of collect your thoughts before rushing into it as well. With ortho X-rays, an important thing is that you always want to say that you would want 2 different views. So you would want an AP X-ray and lateral typically. You can get other views, but like for 4th year, I think all you need to know is AP and lateral. So again, TARP is the mnemonic we use. So the type for this one, instead of lateral or supine, is AP or lateral, the main 2. You want to talk about the area of the body that you see. So you want to mention whether it's right or left, and it usually should be marked on the X-ray that you're looking at. And also, obviously, which joint you're looking at. In ideal situations, you would want to see the joint above and below, but typically that's not really what happens. Again, rotation is a bit more difficult to see in an X-ray, but it's important because it, again, might distort what you're looking at. And penetration, so just the quality of the image, basically. So the mnemonic we use for this is ABCS. So A, we're starting off with is dislocations, subluxations, which are partial dislocations, and any obvious fractures. So you basically just want to look at whether the two parts of the bone or the joint form a smooth line when they're put together. So a good way to make sure you don't miss anything is to trace your way around the bone. So just looking around it like this and taking your time to do it so that you don't miss anything. So here in particular, it's quite a faint fracture that you might not see if you don't trace around it. So that's just a good way to make sure you're not missing anything. And if you are looking at something and you can't really tell if there's anything wrong with it, for example, if it's a hip X-ray, just compare one side to the other, and it might make it easier to identify any abnormalities within the X-ray. Another important thing is in joint spaces. So you want to just comment in if there looks like there's any narrowing, any calcification, which again would be like a brighter white color, or any new bone formation. And I'll show you kind of what that looks like. Okay, so next is B for bones. So firstly, this is the main bulk of the interpretation that you're going to be doing. So you want to comment on if there is any skin penetration. So if there is skin penetration, this would be an open fracture. And if there isn't, this would be a closed fracture. In terms of location, I think the easiest way to do it is just to divide the bone, for example, the femur, into 3 different parts. So that would be proximal, the middle, and distal thirds, and then right or left. Intra-articular, it just comments on if the break is within the joint, so that would be intra-articular, or outside the joint would be extra-articular. And in the image, you can see the different types of fractures. So you've got transverse, spiral, oblique is here, and comminuted is here. So the difference, you can see that between spiral and oblique, it will be quite difficult to see if you're only looking at it from an AP view, which is, again, it emphasizes the importance of getting multiple views, because in the lateral X-ray, you'll be able to see the spiral kind of like staircase looking picture, which will indicate that spiral more than oblique. And yeah, comminuted is just basically, it just means that the bone fragments are shattered. Okay, and again, with a bit more with bones, you can comment on if there's any displacement. So any translation, rotation, angulation, or shortening. And you can see from the images that I've the image I've put up. So translation is just about how much the bone is displaced from where it is meant to be. And an important thing with displacement is that we always speak about the distal fragment in relation to the proximal fragment. So for example, in a humerus fracture, if there is displacement, you would say that if it's like this, then you would say that it's either medially or laterally displaced, and we're looking at this part of the bone rather than this part, and that's where we're commenting on. Okay, and the last one, for C is cartilage. So sclerotic and lytic changes, and this is kind of important for any rheumatological conditions like osteoarthritis or rheumatoid arthritis. And sclerotic changes basically means that there's an increased density in the bone. So you can see that in here, it just looks a little bit whiter. And lytic changes is more destruction of the bone. So here, it looks less dense. And S. That's for soft tissue. So any swellings that you can see, any effusions. So here you would be able to see a swelling, and it's important to comment on that in an X-ray, or here it's a bit less dense. That would be an effusion. And also any foreign body. So this is the point where you would talk about if you can see any, for example, hip replacements, screws, anything like that, important to talk about. Okay, so yeah, so just like with any X-ray again, summarize what you can see, suggest any further investigations. So some easy ones you can say for ortho X-rays are a neuro exam of the joint. Any additional views would be easy to say as well. Most often than not, so for example, in an OSCE, you probably only get one view, so you can just mention that you would get alternative views, and possibly a CT as well. One main thing that they talk about in ortho as well is the 4 Rs. So that's resus, reduce, restrict, and rehabilitate. So this was kind of drilled into us last year. Resus is the most important thing you want to do first. So you want to ensure that the patient is stable before you try to do anything with the fracture. And that's kind of looking at an A to E approach, which you'll become more familiar with throughout the year. And it's just about kind of attending to the thing that would kill the patient first. So this is kind of to do with any major trauma situations. You always want to resuscitate the patient first. Reducing means you're just putting the fracture back into whatever normal position it was in. Restricting the area is where you would put casts or braces on, and rehabilitating the patient, just getting the patient mobilized again. And just to touch on, there's some important classification systems that they use in orthopedics. One of them is the Garden classification, that's for hip fractures, and this is quite a high yield topic. So I would definitely take your time to go through it and memorize it. And it's important because the higher the stage indicates the worse the fracture is. And it basically means that the blood supply to that region, so the neck of the femur, so around here, the head of the femur, the blood supply is more compromised, and so they might need more extreme surgery. And that's kind of looking at stage 3 and 4, rather than 1 and 2 might be kind of screws is possible. The next one is the Weber's classification, and that is to do with ankle fractures. So we base this off of the level of syndesmosis. So that's here, which is where the bones of the ankle joint are held together by the ligaments. So class A would be below the level, class B would be at the level, and class C would be above the level. And this is important because the more proximal the break gets, the more unstable the fracture is. So a class C fracture is more unstable and typically would need something like surgery, whereas the other classes might be managed with more conservative management. A quick one to mention is the Salter-Harris classification. This is more of a pediatric thing that you might see in clinic or in fracture clinic, for example. So kind of important one just to be familiar with at least. Okay, this is just some spot diagnosis. Does anyone want to take a guess? If not, that's fine. I can go through it. So this is osteoarthritis. I'll just go through it. So LOS is the mnemonic we use to just remember the features of an osteoarthritis X-ray. So we can see that we're looking at the knee joint here. So L is for loss of joint space, so that you can see that there's some narrowing here of the joint. Osteophytes just means new bone, like bony growths, and you can see that here. So it isn't a smooth line, which you would expect to see in a normal X-ray. Sclerosis, so that is, like I mentioned, new bone formation, so increased density, which is around here. It looks whiter, and subchondral cysts, which is here. And they're just darker, more defined areas near the joint. So yeah, this is an important high yield one to know. Anyone want to take a guess for this one?
Is it rheumatoid arthritis?
Yeah. Would you like to explain why you think it is that?
Is it subluxation?
Yeah, so the main thing you can see in this one is ulnar deviation and joint subluxation. Yeah, so you can see that this side is the ulnar side of the wrist, and the hands are kind of pointing towards that way. We were told that it's a lot more rare to see this kind of presentation now, because there's a lot better treatment and people are being seen quicker and identified to have rheumatoid quicker. But it's kind of one of those textbook ones that you should definitely know about. So again, less is the mnemonic we use. So loss of joint space. So you can see there's a lot less joint spaces in here. All the hand bones are kind of squished together. There's erosions, soft tissue swelling, which you might be able to see more obviously in something like a knee X-ray, and see-through bone, so osteopenia. So those are the main things that you want to see in this X-ray. And an important thing, yeah, to be able to differentiate between osteoarthritis and rheumatoid arthritis. But you can definitely use like the vignette or the background clinical picture to figure out which one's going on, because sometimes these features are kind of non-specific. So osteoarthritis is more wear and tear, whereas rheumatoid is an autoimmune condition and it's about actual inflammation of the joints. So there's abnormal growth of tissue within the joint capsule, and that releases cytokines which attack the joint. So that's important to know about for rheumatoid. This one, Okay, that's fine. I can go through it. So this is a bamboo sign. So typically this is associated with ankylosing spondylitis, but it is quite a late sign. So not very commonly seen in clinical practice. It might be seen in kind of your AKT situation. The more common sign that you might see on a hip or abdominal X-ray is sacroiliitis, which I'll show you in the next slide. But in terms of this bamboo sign picture, these wavy lines, is because the tissues of the intervertebral discs become ossified and they kind of connect together, and that's what causes this wavy line. So see, these are some of the other signs that you might see. So here's sacroiliitis. So this is obviously in a hip X-ray, but they might give you an abdominal X-ray, and it's just something that you need to spot. The dagger sign is this line here, this unilateral line, and that's because these spinous ligaments ossify and they just form together, basically. Okay, so this one is subtrochanteric fracture. So we can see from this X-ray, this is a closed fracture because there's no penetration of the skin. It could be a bit better exposed because we can't really see all the parts. It's an extra-articular fracture because it's outside the joint. And it's an oblique fracture from what we can tell. You don't have multiple views. And it's in the proximal third of the femur. So that's kind of the main points you would want to hit when you're describing. So this is a really useful diagram that I found because, like I mentioned before, like being able to identify the different types of fractures and hip fractures is really important because it changes the type of management that you will be giving the patient. So here we've got intracapsular. So this is so these would be intracapsular, these would be extracapsular. And you can see that by these, there's different kind of managements that you would do, and you guys can kind of memorize this or like just understand it a bit more later on. So that's the end of the tutorial. If you guys have any questions, please just unmute or type it in the Q&A section. And please do fill out the feedback form just so that we know how to improve in the future and make the tutorials better and more useful for you guys. But yeah, if you guys have any questions, we're happy to answer either about anything we've talked about or about fourth year, anything. And don't worry too much if you don't know the answers to the questions at this point in time. It's really good that you guys are even joining these tutorials this early on in the year. And it will all kind of come into place by the end of the year.
Could you share the feedback form in the chat, please?
Yeah, sure.
Thank you for the tutorials, really good.
No worries. Yeah, I forgot to send the link, 1 second.